70-year-old female, uh, housewife by profession, was having history of systemic hypertension since last 5 years. She's taking daily medication for that. Was mainly presented here with complaints of jerky movement in right upper limb and lower limb. One episode lasted for less than 1 minute, and after that she was not responding well to the verbal commands.
Okay.
So for that time, they brought her here. It's like 2 hours she is in altered sensorium. And she is also having a complaint of one episode of a fall when she visited temple 10 days back, and that time she has a episode of severe headache, giddiness, and she fall over the stairs. And then they next day morning they visited the orthopedician for the complaints, and they found there is no fracture any, and was found to have just a local little myalgia was there. So for that symptomatic management they give, but on initial evaluation they found that patient has a very severe low HB, like HB was 3.5, and so they advised for admission. So she got admitted there, and primary evaluation they have done, and has given 5 units of PRBC transfusion there, and with HB of 9.5 she got discharged, but her giddiness was still persistent. She has loss of appetite with reduced daily activity.
What are the indications of blood transfusion in ICU or emergency room? Indications for blood transfusion.
Patient with some hemorrhagic, patient is present in shock.
Hemorrhagic shock.
Hemorrhagic shock.
Okay.
Then patient with severe anemia, HB less than 7, or patient with congestive heart failure.
Okay.
And,
so less than 7, or patient is having associated cardiac disease, coronary heart disease, or congestive heart disease, valvular heart disease, anything. Okay.
So she got blood transfusions there. After that she was still persistently tired with loss of appetite was there, and she, on past further asking, she also like bystander told, she has a weight loss around 5 kgs in last 3 months, approximately 5 kgs in last 3 months, from 50 to 45 kgs. So that was for the history.
Okay.
Then on here first, when initial evaluation we are doing, that time also she developed one more episode of generalized like a focal seizure, like involving jerky movements of right upper limb and the lower limb. So after that, initially we have given patient lorazepam to arrest that episode, and still it was persistent, so we have given the Levipil loading dose at that time. And after that it got subsided, but patient sensorium was still low. GCS was...
When you have somebody with one side seizure activity, when you call it as, when will you call it as focal seizure? Is it focal seizure or generalized seizure?
Sir,
only one side movement is there. Is this focal seizure or generalized seizure?
Focal seizure. Focal seizure.
We can take it as focal seizure, sir.
But consciousness?
level of consciousness.
Impaired or
Impaired. Then once it is impaired, then it is generalized only. Because we don't know whether that side is not moving because of some other reason. Once the patient is losing his consciousness, it has become generalized. Okay.
focal seizure with impaired consciousness.
Impaired consciousness can be there, but then that will become generalized. It starts with focal seizure, then loss of consciousness or spreading to other areas, then it is becoming generalized seizures. Okay.
Okay, so at that time initial evaluation was done, and the patient has little drop in saturation also. So started on supplemental oxygen by nasal prongs, and point of care labs was done. And in that one VBG showed calcium was elevated. It was 2.09.
Okay.
So the thinking like that hypercalcemia has caused her this seizure episode. So for that treatment we have started, like rapid hydration we have started. Along with that, patient also has a hypokalemia. So diuretics we didn't start initially. It was 2.9. So, but after giving a supplemental correction along with that, then diuretics was also started. But patient has a persistence of that seizure episode. Like one more time after 30 minutes, she developed one more episode even after giving.
First of all, you have to manage the seizure episode here. It may be due to hypercalcemia, it may be due to something else, it may be due to like a stroke, we don't know. But first of all, you have to manage the seizure episode in this patient, then only we can treat the hypercalcemia. How do you manage the seizure here?
Seizures is first we have to airway, we have to see
Protect. We have to protect the airway because his GCS is very low. Okay.
So
Normally when GCS is low, less than 7, you intubate. But which all conditions you don't intubate when the GCS is low? Which all condition in emergency room you avoid intubation. Hypoglycemia is one important condition where even if the GCS is very very low, we don't intubate. Second thing, postictal. All seizure patients with postictal confusion, if you intubate, then all your ward will be full. Neurology ward will be full of ventilator patients. Again, seizure is one condition where the patient's GCS is very low. So we don't intubate. We try to manage the patient with your anti-epileptic drug, and the last resort only intubation and mechanical ventilation. Okay, how do you manage this patient?
So first we have just observed for with anti-epileptic drugs.
And I am asking the stepwise approach to seizure management.
First, sir, we have just secured the airway.
Airway has to be cleared because secretions can be there, dentures can be there, tongue fall can be there. That all should be prevented. Then
we have positioned the patient.
Then oxygen should be started. That you have started. What is the next investigation immediately you have to take in seizure? GRBS. Sugar has to be checked immediately. Okay, then can hyperglycemia can produce seizure?
Yes.
Hypoglycemia can produce seizures. Both can produce. And can seizure produce hypoglycemia?
Yes, sir.
Everything is possible. So sugar has to be checked first. Then
sugar was normal for this patient.
Then what?
Then, sir, we have started on loading doses of anti-epileptics.
How do you manage? Suppose you are the person here. How do you manage this case? Patient is having status epilepticus. How do you manage?
Basically, airway breathing.
Okay, that's okay. That he has already told.
Then, because benzodiazepine we will give.
How do you give?
1 milligram IV.
0.1.
If you don't get cannula,
IM 4 mg midazolam.
IM or nasal midazolam is available in our hospital. It is available. You should try that. Okay, IM is also good. Okay, then you try to put an IV line. Okay, then next drug.
Next, sir, we have given Levipil was given.
Levetiracetam. What is that? Loading dose?
40 to 60 mg per kg.
Okay.
Up to 4.5 grams.
Okay. That can be loaded. Okay, then suppose the seizure does not control with that.
So then we can repeat the dose.
One more time we can repeat
the dose.
Okay,
then we can go for other second line agents also.
Okay, what are the second line drugs?
We can go for fosphenytoin, phenytoin that we can give as like 20 mg per kg.
20 mg per kg. What is the difference between fosphenytoin and phenytoin?
Sir, fosphenytoin can be given at little higher rate, like 150.
Faster rate.
Okay,
then
150 mg.
One more difference you tell.
That can be diluted in dextrose.
Dextrose. So two important things. One it can be diluted in dextrose solution. Other one should be diluted only in normal saline. Okay. Here it can be given faster. 30 minutes you can finish it. Okay. So that can be given. If the patient does not improve with that also, then you go for mechanical ventilation, intubation, complete paralysis. Okay. Suppose you don't do all these things. What is the problem? Why we are worried about so much?
Sir, cerebral damage will be there because of
cerebral hypoxemia, damage can occur. That's why. Okay. So you have to treat this first, seizure. Then you treat the hypercalcemia. How do you manage the hypercalcemia in emergency room?
Sir, first we have to...
First of all, you have to take some investigation before treating this patient. Suppose you know that this is hypercalcemia, you should take some blood test before that. What are the tests? Albumin. Okay, albumin can be done. Corrected calcium. Normally it is useful especially in hypocalcemia, then hypercalcemia, but even then you should take. Okay, anyway you told about corrected calcium. Tell me the formula. Point 8.
0.8 plus serum calcium minus
Okay, so that will give the corrected calcium. Okay, since it is higher, then even if you correct it, it will go a little more higher. Okay, so what is the difference between normal hypercalcemia and malignancy-induced hypercalcemia? Here the patient is having hypercalcemia.
Hypercalcemia.
What is the difference between a hypercalcemia due to hyperparathyroidism or sarcoidosis, tuberculosis, and malignancy-induced hypercalcemia?
So there.
We don't know all these things. We are treating the patient first time. How do it differ in your initial lab investigation?
Malignancy-induced hypercalcemia, other electrolytes.
The level of calcium will be very high in malignancy-induced hypercalcemia. The level. So it may be around 14, 15, 16 like that. Whereas in your hyperparathyroidism may be 11, 12, maximum 13, that much. Okay. So even in sarcoidosis it is like that. It is very minimal elevation in the calcium. Okay. So here you have a patient who is having hypercalcemia and seizure. You have effectively managed the seizure. Okay. Then you have to treat the hypercalcemia. Before that, you have to take some investigation. What is the investigation you take?
Serum PTH levels.
PTH has to be taken. Okay. Serum PTH has to be taken. Then
Sir, phosphorus along with that.
Okay. So phosphorus, serum PTH has to be taken before starting any investigation.
Vitamin D.
Vitamin D. If he is taking vitamin D regularly, then you have to take vitamin D for vitamin D toxicity. Okay. Levels you have to check. If he is not taking unnecessarily, no need to take it. Okay.
Then, sir, if you are suspecting a like, what are the routine
Okay,
labs?
before
like
treating, you tell me the investigation. The basic investigation should be only two. One is albumin, then alkaline. What is that? PTH. These are the basic investigations. Tell me other investigations in hypercalcemia.
So we have to do the liver function to see ALP levels also.
Alkaline phosphatase should be checked. Why alkaline phosphatase is important?
So it is a marker for both the cholestasis and also for the bony involvement.
Here what is important? In hypercalcemia case, what is importance?
So in osteolytic lesions with some bony regeneration, the ALP levels will be higher. So, but in other malignancies where there is a sclerotic lesions, the ALP level will be in the normal range.
All bony lesions except in multiple sclerosis, it will be elevated. Okay. So if there is a bony lytic lesion and you are not seeing the elevation of the alkaline phosphatase, then it is multiple myeloma. It is elevated something else. You have to check what it is. Okay. So alkaline phosphatase has to be done. Well, same like that, you have to take some X-rays of the large bones, sternum, like skull bone. All these things has to be taken. Okay. What changes can be seen in multiple myeloma?
Lytic lesions in the skull and the vertebral bodies.
Vertebral bodies. Okay. So that alkaline phosphatase is one investigation. PTH, alkaline phosphatase. Then phosphorus also you have taken.
And now if you are if ALP is normal, serum globulin levels and albumin levels.
Okay. So albumin globulin ratio you have to check. Okay. Where will you get AG reversal?
Mainly in this multiple myeloma.
Multiple myeloma. Can you get AG reversal in conditions which can produce hypercalcemia other than multiple myeloma? Any elevated globulin can be seen in tuberculosis. It can be seen in sarcoidosis. Okay. So this AG reversal is not an isolated phenomenon seen in multiple myeloma. You get in many types of chronic inflammation. Okay. So, but we have to do that. AG reversal is a very prominent feature of multiple myeloma. Okay,
then sir, we can go for the specific test we are suspecting myeloma.
What specific test you have to do?
Serum protein electrophoresis.
Serum protein electrophoresis can be done. Okay.
Then serum kappa lambda.
Okay, kappa lambda
And
light
the,
chains should be
and the immunoglobulin levels
should be checked. Okay.
IgG, IgM,
So basically, this much you have to do for ruling out multiple myeloma. But other condition, PTH already done. Sarcoidosis, tuberculosis, other things. How do you?
Serum ACE levels.
ACE levels should be done. Is ACE levels are positive only in sarcoidosis?
No, in granulomatous condition.
Many
also,
other granulomatous
TB,
conditions also you can get ACE levels elevated. Okay. What else you can see in sarcoidosis?
There will be in chest X-ray. There will be the hilar lymphadenopathy.
Hilar lymphadenopathy, fibrosis. Okay. Okay. Then tuberculosis again same thing. Lymph nodes and X-ray should be taken. Okay.
And the sputum.
Sputum positive. Okay.
Then we can go for tuberculin test.
Manto test. Okay. How do you differentiate sarcoidosis and tuberculosis in terms of Manto test?
Sir, it will be 0.6 to 1 centimeter.
Sarcoidosis and tuberculosis, Manto test. Emergency medicine PGs, they no need to know about that. But you should know. Sarcoidosis, it will be negative.
And here
That is a diagnostic test. Okay. What other skin test is done for sarcoidosis? There is a skin test. What is it? QIM test. QIM, no? QIM test. Okay, that should be done. But that and all nobody does nowadays. Okay. They take the patient for nuclear medicine scan. Okay. Panda sign. You know that?
Yes.
Huh? Should know. They should not know. You should know. Okay. Anyway, how do you manage hypercalcemia? Sir,
first we have to see like hydration of the patient, rapid hydration and forced diuresis. We have to do. So with like hydration.
Is it forced alkaline diuresis?
No, forced
diuresis. Where will you do forced alkaline diuresis? Barbiturate poisoning. Okay, there are some other poisoning also. Barbiturate poisoning is a very important condition where you could do forced alkaline diuresis. Okay, here it is forced diuresis. Okay, you give large amount of volume. Okay, how do you give volume resuscitation in this patient?
Sir, first we will give the bolus fluids. In this patient, we have given around 1 liter of the bolus fluid, and then we can give at around 200 ml per hour.
Okay.
Seeing the patient's cardiac status and patient is not enough fluid overload, right?
Okay.
So, and then we can start the diuretics with maintaining urine output around 100 to 150 ml per hour.
Okay.
So even with that,
so give fluid with Lasix. Okay, that removes calcium along with the fluid. Okay. Only thing is patient can have chronic renal failure because of either multiple myeloma or this hypercalcemia itself. Patient can have acute on chronic renal shutdown. So that may create sometimes problem. That patient may require dialysis. Okay. So if you are not able to resuscitate with fluid, then go for dialysis. Okay. Then other than fluids.
Sir, we can give a calcitonin subcutaneously.
Can you give nasal calcitonin? Yes or no? This answer is no. Here you cannot give. Nasal calcitonin is used in osteoporotic areas, osteoporotic conditions, not in hypercalcemia. Here only subcutaneous should be given.
4 units, like 4 units per kg.
Okay.
As we can give. That also one dose we have given initially. And after that we repeated the serum calcium level and it was start coming down. Okay.
In malignancy induced, what are the differences you see after your investigation and after initial management? What happened to the PTH in malignancy related hypercalcemia?
PTH will be normal.
PTH will be normal. Okay. What is paraneoplastic syndrome which produces hypercalcemia? What hormone is produced there?
PTHRP.
Related hormone. It is not PTH. PTH will be negative. Only PTHR will be negative. No, sorry, increase. That we cannot do that investigation in our routine practice. What happened to the calcium after your water rehydration in malignancy induced hypercalcemia?
Sir, usually it will not respond
It
that
will not
well,
respond like
nor
this condition. Okay.
parathyroid related.
Parathyroid related problem. It will not respond or late response will be there. So you are given fluids, you are given Lasix, you are given calcitonin injection. What else you can be given?
We can give patient zoledronic acid.
Zoledronic acid. Okay. What are the prerequisites for zoledronic acid?
Like
Anything you have to be cautioned about?
flu-like symptoms can
Flu-like symptom is not a very
reaction.
big problem in ICU.
Allergic
Creatinine. So renal failure, you have to be very careful. You should avoid this. That's all. Okay. But that will definitely help in this patient. Okay.
Then, sir, we can go for denosumab, which is the
Okay. That's a newer drug that can be given.
120 units.
Okay. Then what else?
Dialysis we can do if it is
Dialysis can be given. Okay. Where you use steroids in hypercalcemia?
Malignancy.
Malignancy, it can reduce the size of the malignancy. Inflammation can come down. Sometimes it may be helpful in hypercalcemia also. What is the action? Sarcoidosis is one condition where steroids are really helpful in reducing the calcium. What are the actions of steroids in calcium? Calcium metabolism?
It will reduce the
absorption from the intestine. That is one important action. And sarcoidosis, it's a different action. It reduces the granulomatous tissues. Okay. What happened to these patients' calcium afterwards?
After it becomes like 12.5 when we repeated after 8 hours.
8 hours.
Then we continued the same treatment and put a patient on the calcitonin.
Okay. Subcutaneous calcitonin. What is the final diagnosis before discharge?
Patient was actually, sir, not even responded to the anti-epileptic drugs.
Okay.
So then patient also has the low GCS. So patient was intubated.
Okay.
And patient has given the anesthetic agent like midazolam. Infusion was started.
Okay.
And same time EEG was also attached to see patient is in non-status.
Okay.
Epilepticus. So for that time with Mida's infusion also the patient's burst separation was not achieved. So that's why again ketamine infusion was also started, and after like 6 to 8 hours of that, after that only burst separation was achieved.
Okay. So in a patient, that is a different question, in a patient whose seizures are not able to control with your routine drugs like phenytoin, phenobarbital, and the seizure increases every time when you give phenytoin and phenobarbital, what will be the differential diagnosis for you?
Sir, patient can have is like space occupying lesion in the brain.
That medicine BG should not tell. Emergency medicine BGs can tell. What metabolic condition will increase with phenytoin, phenobarbital, all these things, and seizure increases, urine color will be red in color. What is that condition?
Porphyria.
Porphyria. What porphyria? There are a lot of porphyrias. Acute intermittent porphyria. There you get seizure will not be controlled with your routine medication. Here the reason for the seizure is hypercalcemia. Okay. Both hyper and hypocalcemia can produce seizures. Okay. Here the reason is hypercalcemia. We are not able to control the hypercalcemia. Maybe it is related to malignancy. So we need more investigation to make a diagnosis. PET scan may be required. Okay. So what ECG change was there in this patient?
Short QTC was there around 330 milliseconds.
Okay. That's all. Nothing else.
Yes, sir. And sinus tachycardia was also there.
Okay. Anything else you want to add? So this is a case of hypercalcemia. You have to be very careful. The investigations only will help you to treat the patient. Because if the alkaline phosphatase is elevated, then it is hyperparathyroidism. If the alkaline phosphatase is low, then mostly it can be due to malignancy or sarcoidosis or something else. Okay. So not alkaline phosphatase, your parathyroid hormone. So that investigation is very, very useful. Okay. Thyroid test is done?
For this patient, it was normal, sir.
It was thyroid.
Hyperthyroidism can also cause the hypercalcemia.
Okay, so that is normal. Okay, anything else you want to add? you want to add something? Okay, thank you.